Well, thank you very much for the invitation. It really is a pleasure to be here. I've been a patient myself in the last couple of years, not with melanoma, but in the NHS, and it's given me sort of some personal insights into, just as some of you have said, how impotent you can feel as a patient in the NHS. And I suppose, how important every clinic visit is, the language that's used. And I found that really helpful, actually. But I'm delighted to talk to you today, mainly about TILS, and look forward to questions at the end. And please come and find me in the break. I'm very happy to go through things. So I am a medical oncologist. So like Pippa and Mark, I give non-drug treatments for melanoma. But the other thing I do is I lead a type of immunotherapy called cellular therapy. And I do that across all solid tumours. And the type of cellular therapy that I'm going to talk to you about today is TILS. But I am going to touch upon some other types because I think these are just as potentially relevant to melanoma, and the principles that underlie them and what we're trying to achieve with them will also apply to melanoma, particularly potentially subtypes of melanoma that we've talked about, the rarer ones that might not, or don't seem to display much sensitivity to our current immunotherapies, to your ipilimumab, nivolumab, pembrolizumab, and so on. So, is that going to work? There we go. So you've sort of seen this slide already. And this is a slide that Pippa showed. And it's showing you patients with melanoma surviving over time. This is skin melanoma, it's important to say. And it's showing you how many patients survive over time if they're treated with ipilimumab and nivolumab in red, nivolumab in green, or ipilimumab in black as a first treatment for metastatic melanoma. And not so long ago, this slide used to be put up to highlight progress, a bit like Pippa did. From my perspective, I guess I see it and I use it in a slightly different way now, and I use it to say we need to do a lot better. So it is amazing that you can have an advanced solid cancer like melanoma, for which there used to be no useful treatment options, as you know. And actually, despite there being, using old-fashioned language, secondaries in the liver or the lung, you could have roughly 50% of patients well 5 years later off treatment. That is remarkable. But at the same time, it means that when you're in your clinic room meeting a new patient, or if you are the patient or your relative is the patient, saying that you have roughly a 50% chance of being alive in 5 years' time is not good enough. And that's really how I see this curve now. And so there's an awful lot of work to do. And the reason that I'm here talking about TILS and cellular therapy is that we're all very motivated to try and use the immune system in different ways to benefit patients or broaden the reach. And the reason is it does seem to be, at least for patients with advanced melanoma, it seems to be by using the immune system, we have a chance of long-term cancer control. And that doesn't so far seem to be common to other type of approaches. And that's why there is so much general buzz in oncology in general about using the immune system and trying to get that truly long-term control of cancer. So this is a cartoon which is sort of summarizing 3 types of cellular therapy. Cellular therapy, as it sounds, is using cells. It's using immune cells to try and tackle cancer. And this summarizes 3 different approaches, and I'm going to talk about them, the upper 2 in less detail, but I am going to come to them. And the adoptive part, so this whole method, if you like, or modality of treatment is called adoptive cellular therapy. The adoptive bit means moving the cells from one place to another. And then the cellular bit is cells and the therapy is self-explanatory. And at the bottom of the cartoon, you can see a cancer patient and you can see that the TIL therapy is highlighted there. And what I realise I haven't done is explain to you what TIL is short for. Many of you will know, but I'd like it to be completely clear. So TIL stands for tumour infiltrating, so going into tumours, lymphocytes. And there are different, lymphocytes are a type of immune cell. There are a couple of different types, but the type of immune cell that we're interested in getting when using are T cells, as Pippa was highlighting. And for TIL therapy, the way that this starts is with a small surgery, which I will come to. So you're taking immune cells from the tumours themselves. The other two approaches above, T-cell receptor therapy or TCR therapy in the middle, or chimeric antigen receptor T-cell therapy, CAR T-cell therapy, that you might have read about, which has transformed some blood and lymphomas, some blood cancers and lymphoma, start with blood. They're slightly different. So we're going to focus on TILS, but finish by talking about some of the other approaches and how they may come to the fore in the future for melanoma patients and beyond. The reason that in solid tumours, so in contrast to leukemia, for example, or lymphoma, the reason that we can use tumour to try and make a cell product, a cellular therapy, a bag of cells, is that some solid tumours, and melanoma is an example of this, are immunogenic. What does that mean? It means they generate an immune response. They're visible to the immune system. And I didn't realize till last night, I should have put a melanoma slide in here. This is actually lung cancer, but it doesn't matter. So to the right of the green line, squiggly line that I've drawn on, you can see, to me, it sort of looks like frog spawny stuff in the middle. And that's non-small cell lung cancer, type of lung cancer. But to the edge, the smaller, more dark blue cells are T cells. And they're trying to get to work against the tumor. There's a tug of war going on, if you like. And so this is why we can resect a piece of tumour and from it try and isolate those immune cells that are already in the tumour and already trying to get to work, and try and engineer them or modify things so they might work better. And that's what we're going to come to. So the title of this slide is Lifileucel manufacturing. So Lifileucel is a TIL therapy. It's a TIL therapy that was developed by Iovance Biotherapeutics, you can see at the bottom of the slide there. And Iovance have really been leading the sort of modern day TIL trials. TIL therapy has been around for some time, since the late 80s, early 90s, and it was pioneered by a surgical oncologist in the States called Steve Rosenberg. But technically, it's very challenging to implement this. There's lots of regulation around it. And also, over the time since it first started being developed, for good reasons, we've had the implementation of ipilimumab, nivolumab, pembrolizumab, and that's probably slightly delayed its introduction. But this is what happens. So a patient will come into hospital to have a surgery, and ideally, or most often, that surgery is of something that's very easy to access, ideally a day case. It's difficult to justify large surgery with morbidity or chance of making you unwell for the purposes of this type of approach. But it's difficult, I suppose, to define exactly what is acceptable. What we have sort of said is that, up to 3 days in hospital after a surgery is probably okay. I think the exception to that is if you're needing to have a surgery anyway, and this is with a future lens. So if you, for example, have melanoma affecting your small intestine and you're bleeding into your small intestine and it needs to come out, it'd be great in the future if you could possibly not just have a surgery to remove the tumour, which will literally get put in the bin, but actually that tumour could be used to make a treatment for you and kept in the liquid nitrogen, as I'll come to, until you may or may not need it. And so what we do is we go into theatre with the surgeons. We do this under very highly regulated conditions because I need to be able to demonstrate the journey of the cells that I'm going to give you back from the tissue in theatre all the way to the manufacturing facility, all the way back into your body. And I have to be able to demonstrate exactly what's happened at all points from a temperature perspective and how that's been looked after. And that's to protect patients. And so we're in theatre, it's a no-flow environment, so people can't come in and out. It's just you, us, the surgeons. We receive your tissue and we tidy it up. So we take away any fat, we take away any debris, we take away any dead parts of the tumour, and we try and give as healthy fragments of tumour as we can. And we put them into a sterile flask, which has some media in it, or things that support the health of that tissue. And that flask goes back to a manufacturing facility where they add a little cocktail of cytokines and other things. Cytokines are things that orchestrate the immune system. They sort of guide it along and shape what happens in the body. But they're dropped into the flask to help the immune cells, your T cells or your TILS, to expand up to higher numbers. And there's a so-called REP phase that you can see at the top there. That stands for rapid expansion. And that's a phase where once you've dropped in this cocktail, there's rapid expansion of the TILS or the T cells in the flask. And at the end of a 3-week period for lifileucel, you end up with a flask with many billions of TILS. And the idea is that, and those many billions of TILS will go from the flask into a bag, and that bag of cells will eventually come back to you, but at first it's frozen down and kept in liquid nitrogen. And annoyingly, or at least with this approach, with lifileucel, it's not the case that every single cell in that bag is going to react or recognize your tumor. But there'll be lots of sort of bystander cells. But you're hoping that amongst those many billions of cells, you will have expanded up the bona fide cancer-killing cells to much higher numbers than they were at the beginning. And that's really what you're trying to do. This is the simplest approach. And this exact approach has been around since the late 80s. And I will come to what sort of 2023 versions of this might look like. And so, I think we skipped what's happened there. Perhaps not. So, what happens next? So you've had your surgery. For this particular trial, you had your surgery, you went away, but treatment was planned as soon as the treatment was ready for you. And the manufacturing takes 22 days. So that realistically meant you might have your treatment 6 weeks later, something like that. And this is what it looks like. And it's very different to the type of treatments that modern day melanoma patients have, and I'll explain why. So you come into hospitals, so TILS is given it's an inpatient admission, but for this treatment it is a one-off admission. And I just want to mention that now in case I forget. That's what's unique about this. So for this approach, you're not coming up every 3 weeks for an infusion or every 6 weeks. You're having your treatment as an inpatient. You're going home when you're better and fit to go home, and that is it. Obviously, you need to come back to clinic for follow-up appointments and scans, but your treatment is just what you have in the hospital. And the first bit of it is some chemotherapy, which sounds odd, because chemotherapy doesn't make patients with melanoma live longer. But it's not chemotherapy to kill your cancer. It's chemotherapy to condition or prepare the body to receive the cells. And it's conditioning the body in a couple of different ways. It's so-called NMALD chemotherapy, which stands for non-myeloablating lymphodepleting chemotherapy. What does that mean? Why is it such a mouthful? Well, what it means, the non-myeloablating bit means it's not killing the bone marrow. Why am I saying that at all? It's because in hematology, for blood cancers, leukemia is a cancer of the bone marrow. So for some cellular therapies, you will give chemotherapy that kills the bone marrow before you give a cell treatment back. But you're not doing that here. The second bit is lymphodepleting chemotherapy. And so we're about to give you a big bag of billions of T cells, but floating around in my blood now and your blood are many, many T cells. And so the second aspect of the chemotherapy is to get rid of the current circulating T cells in the body so that when we give you these many billions of cells into the vein, they're not competing with the ones that you have there already to expand up, to persist, to then get to work against your melanoma. And so it gets rid of the competition. And the final bit, and again, this conditioning word is really important because I think it explains it well, is that the chemotherapy can have an effect in the tumor, not killing melanoma, but killing some of the suppressive cells which will potentially shut down the activity or limit the activity of the TILS that we're going to give you into the vein. And so that's why you have chemotherapy. Typically, it depends on the trial, but it's almost always the same type of chemotherapy, 2 drugs, and you have it for roughly 4 days, and you have that a week before you're due to have the TILS. And the idea is by the day you have the TILS, you've got rid of those circulating immune cells. They're all dipped down pretty much to 0, and then you're ready to come in with the bag of cells. And that's the next. I'm the only one who's failing to do this. I don't know why. What am I supposed to be pointing at? Is it you? Is it down here? Anywhere? Still failing. There we go, not pressing hard enough. So the next bit is infusing the TILS. So what does that actually look like? Well, you're in your own room, you're in your own room because you've had this chemotherapy and you're vulnerable to infection. So you need to be in your own room, a bit like a patient would be with a leukemia or a lymphoma. The cells will be thawed in a water bath in your room, and they've come up, highly regulated conditions again, in liquid nitrogen. They come out, everybody has to be very well trained in this. The cells are thawed at the bedside, and then they're put up, and they go into the body, and most often that's uneventful. Like any infusion, there's a chance of having an infusion reaction, but it's not a common event with this treatment. And then after the TIL therapy, at least for this approach, and for most TIL therapy approaches, you receive a cytokine, a word I mentioned earlier, this orchestrator of the immune system called interleukin-2 or IL-2. And that can be given into the vein, which is a bit more toxic, which we'll come to. Sometimes it's given into a pinch of fat under the skin. Sometimes it's given at lower doses or higher doses. In this trial, it was a higher dose into the vein. And at a higher dose into the vein, this used to be given as a bona fide cancer treatment in its own right. And patients used to be pushed and pushed and pushed to maximum tolerance, which would make them unwell, and was a particularly unpleasant treatment for advanced kidney cancer. But that's not what we do here. So you have up to 6 of those treatments, typically 1 a day. And what it does is it causes you to have fever. It's a bit like precipitating a viral infection. You're rigering away, shivering away. But what it's doing, the interleukin-2, is promoting the expansion and activity of the TILs that have gone up in the bag and are now circulating around your body. And that's its purpose. And that's it. So that is your TIL therapy in its simplest form. And that is what we currently have the most evidence for in terms of how well it works, which I'm going to come on to. So Pippa and I took part in this study. And it's a modern-day study, meaning it includes patients who have had modern-day treatments for melanoma, current forms of immunotherapy, targeted treatment, and it gave them TIL therapy to see how well it would impact lifileucel, the one that you've just seen, although it wasn't called that at the time. It didn't have a name. And we always put up these baseline patient characteristics when we're talking about trials. And the reason we do that is we're trying to show that the patients in the trial are reflective or not of patients in the clinic. And you will know that not infrequently, patients in clinical trials aren't perfectly representative of a real-world population, meaning the everyday person in clinic. You know, so patients in this trial did not have melanoma in the brain that was getting worse, for example. And the reason is because you really do want to evaluate, you want there to be some stability, some genuine clinical stability, so that you can really try to understand if the treatment you're giving is safe and if the treatment you're giving has worked. These patients had around 3 treatments before. It could be they had some adjuvant treatment and their treatment in the metastatic setting. It could be because there were American patients too, that they'd had re-challenge with things that we wouldn't do here. But a number of them had a high tumour burden at baseline. These weren't carefully selected patients with minimal melanoma on board. And I would just say, because I'll forget to say it, that in a second cohort of patients, this data looked very similar, within the same trial, but a second cohort, so in greater numbers. This looks like a really unexciting slide, but it's actually quite exciting. And it shows that the response rate, the number of people that benefit and have a shrinkage in their melanoma, is around 35%, so around a third. And that's sort of exciting. It's exciting because in the last 5 years, there haven't really been any breakthroughs for patients whose melanoma has stopped responding or has never responded to the standard approaches. So this really is a breakthrough in that sense, that this has activity in that space. But the more exciting thing is that amongst the patients who are responding to this treatment, the median duration of that response, so how long the response lasts for, it hasn't been reached. We don't know. It's not just 12 months or 30, so we don't know that yet. And that tells you that patients must be doing well, or some of the patients must be doing well, which is great and really encouraging. And this is a so-called waterfall plot. So every bar is a patient. And the bars represent the sum of the size of the tumour. So they'll add up, they'll measure something in the lung and the liver, say, and they add up the sum of the two diameters, and then you're looking for the change. So if the bar's going up, the tumours are getting bigger, unfortunately. And the red blocks there are PD, if you look at the key, progressive disease, which we don't want. But when the bars are going down, it's showing you that the tumours are getting smaller. And so the green bars are a so-called complete response, where all the melanomas disappeared. The blue bars are a partial response, where you've had decent shrinkage, and the grey is SD, or stable disease, okay, where you can see for a number of the patients with stable disease, they just hadn't reached the threshold of more than 30% reduction, but the tumours were getting smaller when this data was reported or written up or presented. Can you see the asterisks is at the bottom? Those are patients with BRAF mutations, and I think that's really important. Not patients with BRAF mutations, but patients with melanoma with BRAF mutations. But it's so important because some of you will know that for patients who have BRAF mutations, often when you stop their targeted treatment, things can move along very quickly and they can get poorly very quickly. So even that group of patients seem to be benefiting, which is really exciting. This is trying to show you, and again, each bar is a patient, that over time, these responses can be durable. So if you look at the dark blue triangles facing this way, it's showing you that those patients have ongoing, are still on the study, if you like, and they have ongoing response in their melanoma. And you can see how far out some of those are. The upside-down blue triangles show you when the first scan showed that the tumour was shrinking. And there is a difference here, and this may be more important, this is as important, I think, for patients and clinicians, but with TIL therapy and other types of cell therapy, the early scan, and the first scan here was done at 6 weeks, tends to show you if you're sensitive to the treatment or not. And if you'll know that that's different for ipilimumab and nivolumab, for example, where sometimes a first scan or a very early scan, particularly a scan at 6 weeks, for example, might be confusing. And with immune checkpoint inhibitors, sometimes things can swell before they shrink. But this is different. That's quite interesting. And the other really exciting thing is if you look at the green triangles, that shows you when a patient had complete resolution of everything, the scan was clear. And so you can see that you can give a one-off treatment back at day 0, okay, and 2 years later, you go into complete response. 2 years later, the cells that I gave you in the bag are long gone and dead, but those cells have somehow managed to reinvigorate your own immune system to then keep getting to work against your melanoma over time, which is a great principle to sort of demonstrate. This is really important. It doesn't look exciting enough, again, but I'm going to talk you through it. So side effects. So 2 things. The first thing was the visit that I wanted to highlight, that this is a one-off treatment. The second bit is the side effects. So the side effects can sort of be divided into related to two main parts of the treatment. Firstly, the chemotherapy. And the chemotherapy, we said it's deliberately trying to get rid of the lymphocytes. It was lymphodepleting. But it will also dip down your red blood cells, and so you can become anemic. Your platelets, your sticky cells in the blood can become low, as well as your white cells, which can mean you can spike fevers and have infection that needs to be treated. And so those are quite common side effects of chemotherapy that non-melanoma patients might be more used to. I think they're fairly easy to navigate. It might mean for you as a patient that you might need a blood transfusion during your admission, you might need a platelet transfusion, those sticky cells, for example, and you might need an injection into a pinch of fat to try and boost up your infection-fighting cells and help them recover a bit more quickly. The other side effects relate to interleukin-2, which was that cytokine that promotes the activity of the TILS that you give. And what that causes, as I said to you, is shivering away, rigors. It can make your blood vessels a little bit leaky, so you end up with fluid in the wrong places. as expected, with the shiveriness, you're spiking fever, and you're feeling generally pretty grotty. And the more of it you have, you feel a bit worse. You don't have another treatment of interleukin-2 until the side effects from the one before settle. But it makes, over time, they make you feel pretty rough. And you've come in and you've had chemotherapy. And sorry, what I didn't mention is the common chemotherapy side effects. You felt a little bit sick, probably. You might have had a bit of diarrhea with it, felt a bit washed out. So you're feeling a bit washed out. Then we've induced something a bit like a flu, and you felt awful with that. So you are feeling pretty rotten towards the end of your second week or so in hospital. But the important thing is the bit on the left, and the AE stands for adverse events, but that's a sort of trial term. So if you think about these as side effects, the higher the grade, the worse the side effect. But what you can see at the bottom is that most of those side effects happen between day 0 and day 14. And that's when you're in hospital under the direct supervision of the clinical team. And so we can actually be with you. You're not at home trying to talk to a hotline and saying, I'm not going to A&E, or, it's not that. It's actually, we're here, we can give you an anti-sickness, we can give you things to make you feel better, get everything to settle. And by the time you're fit for discharge, which is around a couple of weeks later, what you will see is that all of those side effects are petering away. And it was a one-off. So you're not coming in and out of the clinic now for more infusions, that's it. And so you can imagine that you could visit a specialist centre from far away to have this treatment, a bit like people might come from quite far away to have a bone marrow transplant for leukemia or that kind of thing. And this many of you will know that publishing a paper in the New England Journal of Medicine is like winning an Oscar for oncologists. And this is this study was from John Hannon, who's a very well-known melanoma oncologist and kidney cancer oncologist from the Netherlands. And he did it with some colleagues in Denmark. It took 8 years to do this study, but it was a second study, and you can see how recently it was published at the end of last year, that cemented further the potential role for TIL therapy, and showing that this was potentially a better approach than ipilimumab on its own for patients whose melanoma wasn't benefiting anymore from pembrolizumab, nivolumab. So this is sort of bringing TIL therapy a bit more to the fore. Pippa was mentioning, what happens if you show a treatment works when all others have stopped working, you try it earlier. And we have this study open at the Marsden called the Iovance COM202 study, and it explores the use of TIL therapy plus pembrolizumab in patients who have developed metastatic melanoma but haven't had any immunotherapy yet. It's a trickier group to find because many people, for good reason, have had adjuvant immunotherapy. But that's what that's looking at, and it's also looking at TILS plus pembro in patients with head and neck cancer and lung cancer as well. So we're still looking for patients in that situation. What they have to have, though, and it is tricky, so they can't have had any adjuvant immunotherapy. They need to have something that you can remove to make the TIL therapy, and they need to have something else that we can measure to see if it's working on a scan. So they need to have a second lump somewhere. And it's quite difficult to find those patients, but that's a trial that's ongoing. But the data looks good, and the caution that I would ask around this is that I'm going to show you very small numbers of patients. So whenever you see percentages, they get greatly inflated if 1 or 2 patients do well. And so this was some data presented a couple of years ago, but in the melanoma patients, and you can see on the left of your slide, there are only 10 there, but the response rate was around 60%. And you can see on the left there those waterfall plots again, and actually all of the tumour sizes going down in the right direction. And so, as I said, that trial's ongoing, and there's also going to be a phase 3 trial, a bit like this, still pembrolizumab and TILS, but patients can have had adjuvant immunotherapy. And so that isn't open, but that is being developed again by Iovance. And again, with this approach, as you saw before, there's the potential for it to work over a long period of time. I'm really disappointed in myself for my pointer performance. durable responses over time, which is great, but it's early days. You know, the trial is still recruiting, so we have to see how all of that pans out. Susanna, I'm okay to go on for 10 more minutes? Is that right? Yeah? So what I've shown you is the simplest form of TIL therapy, and I mentioned that entire approach has been around since the 1980s, and I wanted to present you more of a sort of modern day version of TIL therapy. And the really nice thing about cell therapy in general is you can do lots of things to make it better. So that conditioning chemotherapy that you mentioned, you could change so that the host, the patient, you, is better prepared to receive the cells. You can do something with the cells and make them better able to kill cancer, and then you can do something afterwards. And that's what you've seen already, because rather than just having interleukin-2, in the trial I just presented, patients are having pembrolizumab. So there's all these areas that you can change things and try and make it better, which is really attractive. And there's an approach from Achilles Therapeutics, which is trying to develop a bespoke TIL therapy, a TIL therapy that's bespoke to your tumour. So you come in and have your surgery as before. In addition, you give a decent amount of blood. And yes, the immune cells, the T cells, are expanded up in the lab, but in parallel, the scientists study the genetic makeup of your tumour. And they understand from that, of the genetic faults in your tumour, which ones are visible to the immune system. But more than that, of the ones that are visible to the immune system, which ones are present on every single cancer cell, no matter how complex it's become over time, your cancer, and diverse. Can we find these these genetic faults that your immune system can see that are ubiquitous, they're everywhere? And then can we teach the TILs to recognize those? And that's what they're trying to do. It takes longer. It takes about 3 or 4 months to do that, which is a problem, and means we need to think about when do you do this? When do you sample the tumour in a patient's treatment? And what you have at the end of that process is, unfortunately, you don't have a bag of cells in which 100% recognise these ubiquitous targets, if you like. You don't. That's what we'd like. But you have a bag that's at least enriched for, or there's a greater abundance of cells that recognise these targets that are on every single cancer cell. And that's the sort of unique thing about this approach. And we have the THETIS study open in melanoma and the Chiron study in lung cancer using exactly the same approach. The issue is that not all solid tumours are immunogenic. They don't all generate an immune response. Some are pretty invisible to the immune system. The commonest types are breast cancer, but perhaps more topical, you know, melanoma that starts in the eye is much less visible to the immune system. So what can we do, and how might cell therapy help? Or can we use cell therapy to help in that sort of situation? It could also apply when, for example, your tumour has become non-immunogenic. So melanoma can be visible to the immune system at the beginning, but it evolves, unfortunately, and it becomes less visible to the immune system over time. And is there a way that we can use cell therapy treatments beyond TIL therapy potentially to help those patients? And just to try and highlight the principle, Pippa mentioned tebentafusp to you. And I don't know if there are any patients here with melanoma that started in the back of the eye, but we mentioned this is the first treatment that's prolonged survival for patients with uveal melanoma. But what I want to flag is really the principle and what you're trying to achieve. The FUSP bit stands for fusion protein. It's 2 proteins fused together, and one end binds to something called a target called GP100, which is expressed at high levels in the tumour. The other end literally pulls in T cells. And so if we give pembrolizumab, ipilimumab, and nivolumab, we think we have to rely on the fact that there's already a tug of war going in the tumour. But in non-immunogenic tumour types that are invisible to the immune system, that is not happening. And so here, you are literally bringing the immune system to the tumour. So I just wanted to show, to finish, how we can use this is not a cell therapy, it's a fusion protein, but I'm going to show you how cell therapy can actually impact in tumour types that are less or not visible to the immune system, and this has implications for melanoma. So I'm going to focus on T cell receptor therapy here, you start by giving lots of blood, like donating blood, but in more regulated conditions, and the T cells are taken from your blood, not your tumour. And in the lab, a receptor is inserted that recognises specific target expressed in the tumour. And we can take a tumour type like myxoid round cell liposarcoma, synovial sarcoma. These are tumour types that have that when they've spread around the body, a bit like melanoma was 10 years ago, the only option is chemotherapy. It doesn't offer you any chance of long-term cancer control, but just by some nuance, there's high expression of a target called NY-ESO-1, 80 to 90%. And so what we were able to do is bring patients in. They give their blood to make the treatment for them that can recognize that target. They have their chemotherapy, just like with TIL therapy, and they just have the cell infusion, nothing else. And this is a patient that we treated with synovial sarcoma, the first patient on this trial. And the bit that's measured at the top, I don't know if you can see that, where there's a ruler, that's in the chest, something that's to the front of the chest, something that completely disappeared at week 6. This is something in the tummy just above the kidneys. You can see it's measured again. These are lumps of sarcoma shrinking down, and again here. And I'm so pleased to tell you that this patient came this week for her 12-month visit. Her treatment was a year ago, and on her scans, her sarcoma, which is a tumour subtype that does not respond to nivolumab, ipilimumab, pembrolizumab, is still shrinking down. So this is just really showing you the promise of cellular therapy, even for tumour types that don't seem to be visible to the immune system. And CAR T-cell therapy is similar, but an inner engine is inserted which can give you more control over what the cells can do. And CAR T-cell therapy has transformed hematological malignancies, completely transformed them. And we're hoping the same will follow in solid tumours. And there is some data that's sort of emerging. This is just one example, and this is in gastric cancer, where CAR T-cell therapy are starting to show some promise. So I will stop there. Thank you for listening. Apologies for the pointer performance, and delighted to take any questions at the end. Thank you very much.